Hi class, my name is Madison Monroe. Today is May 1st, 2022, and I will be going over my case connection for video presentation discussing cases 3 and case 4. Let's start with case 3. Case 3 entails of a 47-year-old man presenting with severe pain to his right great toe. He is unable to bear weight on his right foot and there is no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on the physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed. The results of this individual are below. The plasma urate was 10.5 milligrams per 100 milliliters. Normal is less than 7.0. The urinary uric acid was 215 milligrams per 24 hours. When the normal is 413 plus to minus 78 hours. The case wants us to look at the best explanation for the presentation of gout in this individual. Please explain why the other choices are not consistent with the data and what information you may need to decide the root cause. Our options are the overproduction of purines, decreased salvage of purines, or decreased urinary excretion of uric acid. But let's start at what gout is. Gout is also known as hyperuricemia, which is a form of arthritis that affects the joints, most commonly in the big toe. Gout occurs when urate crystals begin to accumulate and build up at the joint. Urate crystals are caused by high levels of uric acid in the blood. This would make the best answer to be a decrease in urinary excretion of uric acid. Excuse me. Uric acid is produced with the breakdown of purines. Purines are molecules that can be found in the body that are made up of carbons and nitrogen. With a clinical diagnosis of gout, we know that there is an increase of uric acid, which is seen here in the plasma urate at 10.5 milligrams per 100 milliliters, when the normal rate of this is less than 7.0 milligrams per 100 milliliters. Looking at the urinary uric acid resulting in 215 milligrams over the 24 hours, that is around 200 milligrams below the optimal range that we should be seeing. This indicates that there is an issue with the excretion of the uric acid, which is causing an increase in the urate in the plasma. An answer that is a good answer, but not the best, is going to be the overproduction of purines. In the metabolism of purines, the end product is uric acid. The potential for increased uric acid in the blood as a result of an increase in purine synthesis is possible, but it does not directly correlate to an increase in plasma uric acid if there is not a deficiency in the pathway. It is the increase of uric acid that leads to gout, not an increase in purines, because the uric acid comes from breakdown purines. Based on the data that we are given, it would just be hard to prove this since we are just looking at testing of uric acid levels. So this would most likely not be our deficiency or decreased salvage of purines is the least likely answer of decreased salvage of purines is the least likely answer for this clinical presentation. The purine salvage pathway is a pathway that allows for the synthesis of purine nucleotides from free nucleobases. This would be unlikely because of the decrease of salvage purines would lead to a decrease of purines. And a decrease of purines would lead to a decrease in uric acid, and thus would not likely cause gout, since this disease is caused by an increase in plasma uric acid. One way that we can confirm if there is a deficiency in purine salvage would be running a test in which we could see adenine phosphorybosyl transferase levels, and there would be a decrease if there was a deficiency in this. After further discussion with the patient, he does tell you that he recently switched from diet sodas to regular soda because he read that fake sugar in diet soda was bad for him. He tells you he drinks between 4 and 5 liters of soda per day. And just a note, the primary sugar in most sodas is fructose or high fructose corn syrup. Which leads us to the next question. What is the potential impact of this dietary modification on the presentation of gout? Diet can play a huge role in the prevention and onset of gout. There are a variety of food that you should avoid in order to prevent gout. The top of the list of the foods to avoid or drinks are those that are high in sugar or fructose. Food or drinks that are high in fructose are proven to increase uric acid levels in the blood, causing gout. Having 4 liters a day of soda is a minimum of 440 grams of sugar. For the average man, it is recommended for added sugar to be 36 grams per day. So that's a pretty big difference in what we should be doing. Other high purine foods to avoid are red meats, alcohol, organ meats, and seafood such as shellfish. Foods that can help prevent the onset of gout are foods that are low in purines. Some of these can include fruits, vegetables, nuts, grains, complex carbs such as rice, and eating meats in moderation. Let's discuss case 4. Case 4 consists of a 58-year-old woman presenting to the emergency department with progressive fatigue and weakness for the past 6 months. She is short of breath after walking several blocks. On review of symptoms, she mentions mild diarrhea. She has noted intermittent numbness and tingling of her lower extremities and a loss of balance while walking. She denies other neurologic or cardiac symptoms. She has no history of black or bloody stools or other blood loss. On physical examination, she is tachycardic to 110 beats per minute. Other vital signs are within normal limits. The head and neck examination is notable for pale conjunctivus and a beefy red tongue with loss of papilla. Cardiac exam shows a rapid, regular rhythm with a grade of 2/6 systolic murmur at the left sternal border. Neurologic examination reveals decreased sensation to light touch and vibration in the lower extremities. No depression is noted. Hematology consultant on call is asked to see his patient because of a low hematocrit level. Megaloblastic anemia is suspected. So we're asked, which of the following vitamin deficiencies is the probable cause of this presentation? Discuss each option with each deficiency, which is most likely. It is going to be either iron, B6, or B12. Megaloblastic anemia is a subtype of anemia characterized by red blood cells being much larger than average, as well as not being fully developed. The most common case of megaloblastic anemia is vitamin deficiency of folic acid or B12. Common signs and symptoms can be seen with megaloblastic anemia are abnormal paleness of skin, decreased appetite, fatigue, diarrhea, difficulty walking, numbness or tingling of the hands and feet, a smooth, tender tongue, and weak muscles. Our patient has nearly every one of these symptoms that are associated with this diagnosis. So B12 is the most likely vitamin deficiency to be the cause of this clinical case. B12 deficiencies can lead to anemia, more specifically can lead to megaloblastic anemia. The symptoms of B12 deficiency are the symptoms that our patient is presenting. A deficiency in B12 can show fatigue, heart palpitations, and shortness of breath, pale skin, a smooth tongue, diarrhea or constipation, numbness and tingling of hands and feet, vision loss, and behavioral changes. And these are most consistent with our diagnosis of megaloblastic anemia, which is the reason that this is the likely deficiency. It is most likely not a deficiency in B6. A deficiency in B6 is often associated with microcytic anemia, which is an anemia presenting as red blood cells that are smaller and don't have as much color as red blood cells typically do. This contrasts our diagnosis of megaloblastic anemia. Symptoms of B6 deficiencies include skin rashes, numbness or tingling of the hands and feet, cracks of the lips and corners of the mouth, behavioral problems such as depression and confusion, and the potential for seizures. While there are some similar symptoms in comparison, this is not likely our deficiency due to the subtype of anemia, the lack of rash, and the cheilitis. Iron is not likely a deficient vitamin either. When someone has low iron, the red blood cells don't carry oxygen as easily. Having an iron deficiency is a telltale sign of anemia, also known as iron deficiency anemia. This is a condition in which blood lacks adequate healthy red blood cells that carry oxygen to the tissues. Common symptoms associated with this can be seen as fatigue, weakness, pale skin, chest pain, rapid heart rate, and shortness of breath, cold hands and feet, inflammation or tenderness of the tongue, brittle nails, and poor appetite. While this deficiency also carries similarities, it does not explain the neurological issues that we're having with balance issues and loss of sensation. So now we're going to discuss how vitamin deficiency impairs purine or pyrimidine metabolism, and this is important to this, and thus is important to DNA synthesis. B12 is an important cofactor that's required by methionine synthase and for methylmalonyl-CoA mutase. B12 is required for methionine synthase, which catalyzes for the conversion of homocysteine to methionine via the transfer of a methyl group coming from methyl tetrahydrofolate, which creates a link to the methylation pathway through the synthesis of the methyl donor S-adenyl methionine and the path of purine and pyrimidine synthesis. Methylmalonyl-CoA mutase converts methylmalonyl-CoA to succinyl-CoA, which is a part of the oxidation of odd-chain fatty acids and ketogenic amino acid catabolism. So we do see the importance of B12 to DNA synthesis by the regeneration of methionine for protein synthesis, methylation, and the prevention of homocysteine accumulation. Now it also asks to list potential lab tests and findings that would help us in assisting our differential. There are 3 tests that we can use in order to confirm this diagnosis, including CBC, a peripheral blood smear, and B12 folate tests. The big help with a CBC test is it would show if a patient had anemia. A peripheral blood smear could show the subtype of anemia based on the visual characteristics of the red blood cells. This test is a specific indicator for a patient that has megaloblastic anemia. Ordering folate and B12 tests could also be helpful in determining the type of anemia and what deficiencies that may be present. So those are the tests that I would do in order to confirm this diagnosis, but those are my 2 cases for this Case Connection 4 video presentation. Thank you for listening.